Alrighty, well you might have worked out, I didn't hear all of the introduction, I am not Will. I think Will was going to speak about death and dying today. I think right now he feels as though he'd like to, but I'm going to take things back to pre-death, and we're going to talk for the next 20 minutes about young onset dementia. So here's a presentation that I just happen to have in my back pocket, as one does. So now, this is really, really important that we get this right, because people with young onset dementia everywhere are actually counting on us to do things better and to help them to get on with the business of living after their diagnosis. I don't have my bio there. I'm a psychologist with the ACAT and Memory Service, co-chair of the statewide Dementia Clinical Network, member of the Queensland Senate, and numerous other things. I'm not a doctor, I'm not a physician, I'm not a diagnostician, but today I am going to contribute my piece of allied health wisdom. And I do hope along the way to challenge you a little bit and provoke some reflection. Now, it's an arbitrary distinction for our benefit that young onset dementia is defined as dementia diagnosed symptom onset prior to age 65, often shortened to YOD, younger or young onset dementia. Interestingly, whilst it's known as being rare, it is estimated to account for 6 to 9% of all dementia cases worldwide, with emphasis on the word estimated, because we don't actually have gold standard studies on this. So most of our estimates here, our data here in Australia is based on estimates from overseas studies, predominantly from the UK and also from Japan. So I've put together this graphic to try to help you picture. So the first, if we look at the blue, that's actually the number of cases per 100,000 people. So the UK have estimated 54 people per 100,000 of all-cause dementia, whereas in Japan, they've actually got 51. And the only data that we've had come out of Australia from our first Australian study has got ours higher. So it's likely that our rates are actually higher than what the estimates are. And then when we look at breaking it up into cause, hence I've colour-coded them, we've got Alzheimer's disease leading the way in the UK, whereas it's vascular dementia leading the way in Japan. Horror, down in Australia, our leading cause is sitting at alcohol-related dementia, closely followed by Alzheimer's disease. Now we'll see these statistics vary, I think, as the study progresses, but current data, that's how it's actually looking. So pretty scary. So we're not all finding the same data. It's going to differ throughout the world, but generally speaking, the fact that we would appear to have higher rates than anticipated, I find really scary. So thinking about the INSPIRED study, what they have found to date is the time to diagnosis ranges between months and 13 years. So we're talking people who are 30, 40, 50, 60, who are taking up to 13 years with a mean time to diagnosis of 2.5 years. That's a lot of time to be confused. 10.6% of these took greater than 5 years. There was no significant difference between the genders, and there's some interesting complexity around the alcohol-related dementia and typical comorbidities that sit alongside that. Oftentimes people with an alcohol-related dementia have had other not very helpful habits as well, so it can be really difficult to tease them all apart. They're also frequently estranged from their family, which can impact the seeking of the diagnosis and the collateral information giving. And they're also much less likely to have follow-up. Because of the complexities around this particular condition and the estrangement from family, they are much less likely to have follow-up, which makes matters worse. There's been an interesting dose-response discovery. One of the articles showed that even a single hospital admission for alcohol intoxication is associated with a 5-fold increased likelihood of a young onset dementia diagnosis later. We're also seeing CTE. This is the chronic traumatic encephalopathy, the background of the story with Will Smith, which was concussion. And we don't really understand what's going on there, but I expect that with promotion of this, we'll see more actually diagnosed with that. And what the INSPIRED study has told us is that around about 1/3 of young onset dementia has been contributed to by preventable lifestyle factors. So what are some of the challenges associated with young onset dementia? Increased shock. I think many an 85, 95-year-old is not quite so shocked as a 45-year-old. More stigma, less support, and there are less age-appropriate services. There is reduced independence and loss of employment. People feel disempowered and disconnected, and around about 1/3 of people with a young onset dementia diagnosis actually have no familial or no carer, nobody actually living with them, which makes matters even harder. And we know very little about this group because generally speaking, they're not participating in the research. So there's this great big gap of what's happening to those people. So we're talking about a cohort of people who are now mixing in aged care circles, despite the fact that they're in their 40s and 50s. They're reporting ageism and reduced specialist services. They're feeling massive losses and role changes and disengagement. So many of these people are working, trying to work, and can become unable to continue to do so. So they can be quite disconnected. They're often raising a family of their own and also are sandwiched and are providing care for their elderly parents. So I'm seeing people who have a young onset dementia, raising children and likewise supporting older people, which creates a bit of confusion at times when they present to a memory clinic, and there can be the assumption that it's the 80-year-old mother who's the person who's seeking the diagnosis, and it's not correct. And there's more significant financial issues because they're more likely to be participating in paying the mortgage and so on. We're talking about a group of people who are usually physically stronger, and they're also more likely to have an incorrect diagnosis or diagnoses along the way. So the statewide Dementia Clinical Network set about creating a younger onset dementia diagnosis guide. Pleased to say it is uploaded, it is on the Mackay Primary Health Network page, but I discovered today it's really tricky to find, so we're going to be talking about how to actually get that moved. But this is a guide to help GPs and other diagnosticians to work their way through to a more timely diagnosis, because frequently GPs have not seen anybody presenting with symptoms of young onset dementia. Can slow things down a little bit. And another scary factor is, where are the children? We're talking about a group of people who often have children. Interestingly, the prevalence of YOD in Australia is similar to that of MS, very, very similar to that of MS. We know that people with MS, the studies on the children of people with MS put them at a much, much, much higher chance of having some additional mental health difficulties as a result of having a parent with MS. But we have different rules around the YOD. We know a little bit less. But we do know that around about 1/4 of this group have got children who are under the age of 18 at symptom onset. The delays in getting the diagnosis leads to a great deal of confusion. So people don't actually know what they're dealing with. They don't know why particular things are occurring. They don't know what to research. They don't know what to fear. Children are often blaming themselves. So the children are experiencing a radically different childhood, and they tend to be excluded from the services. So they're left out. And I know this because I've often tried to reach the children, and the parents shut up shop around them and won't let anybody get to them. They want the children to remain external to this process. And yet, on the other hand, I hear reports of increasing behavioural issues for the children at school, and still the parents want to shut up shop around them and just deal with things as best they can and keep the children out of it. So the kids are feeling isolated and alone. Karen Hutchinson, who is doing her PhD in this area through New South Wales Uni, would love to hear from anybody who does support the children of people with young onset dementia. She has found that parents are actively preventing engagement of services and professionals with the children, that health professionals are not routinely seeing the children and often don't feel confident about supporting the children either, because most people supporting people with dementia are working in the aged care arena, and there can be a very good reason for that. So they're not quite so comfortable with 6, 8, 10-year-olds. She found that crisis is common, but intervention is rare. And health professionals identify that they do need upskilling in this area. Young people need to have reliable support, even if it is only one person, and it's a bit tricky to access this reliable support. It seems to me as though the schools are going to be best placed. So I go into the schools now and help to upskill them on what's going on, with parents' permission, of course. And the children have highlighted the fact that if they have a friend whose parent has a cancer diagnosis, this all happens very, very differently. And the support options are discussed, and the children tend to know more about what's going on than they do with a young onset dementia diagnosis. We know that children in their teens, the adolescents, tend to self-regulate by opting out. And it often works quite well for them. So they withdraw, they often even withdraw from the house and live elsewhere, and then they can regulate how much they're seeing the parent with dementia, and that helps them to cope. And we know from the parents that they do fear family services becoming involved, so they can tend to mislead. Now, really, really importantly, for people with a young onset dementia diagnosis, we now have Dementia Alliance International. Dementia Alliance International is people diagnosed with YOD, and they're supporting each other. It's absolutely wonderful. They have face-to-face support groups via computer so that people can participate in some peer support right from the get-go. They just need a computer and a diagnosis of dementia. And the more people who use this service, the more the organisation can cluster the support groups around a particular diagnosis or a particular geography or whatever the group members want. So just to have a little look at our language, because it's something that people with dementia are quite critical about, I'm just going to draw your attention to the language guidelines which are released by Alzheimer's Australia in the last couple of years. One of the words often tagged to people with dementia is the word behaviours, and this can be a bit problematic. So I looked it up, and the Oxford English Dictionary defines behaviour firstly as the manner of conducting oneself in the external relations of life, and secondly, the manner in which a thing acts under specified conditions or circumstances. This is really important because often the word behaviour is attached to the diagnosis as though automatically these two things coincide, and we can sometimes forget what's going on, which is participating in triggering or contributing towards a behaviour. So it's something just to think about. So people with dementia are now arguing quite loudly that behaviours or BPSDs, behavioural and psychological symptoms of dementia, can be actually expressions of needs. So how are we supporting that? And what are our behaviours and our contributors towards unmet needs? Now, just to put a human face to this, I'm going to introduce you to Nari and Colin. Nari was 65 at diagnosis, fit, active, healthy, socially engaged, religious. She enjoyed activities and interests. She was working, she was volunteering, she was helping with grandchildren, devoted to pets, excellent diet, wonderful marriage. So she got lots and lots of ticks. She was an assertive lady, and it was her way or the highway. Her diagnosis took longer than usual because her referral in this case took a wrong turn. Colin was anxiously witnessing his wife's decline, yet the doctor in charge of her care was really puzzled about this and said, "What's the urgency?" She was eventually diagnosed by a neurologist who, after diagnosis, stopped looking her in the eyes. And she picked up on that. She drove to her much-loved GP for feedback about her diagnosis. She'd always preferred her driving to his. And the GP removed her licence immediately and without warning, based on the diagnosis. She continued to work for some time and was now walking to work, but she was offered an ACAT, Aged Care Assessment Team approval, and the Living with Memory Loss program, which went over her head. Colin became known as her carer, and her EPOA on some of the paperwork. And this was a really bitter pill to swallow for a strong, independent woman who doubted her diagnosis and continued to work. "What makes him my carer?" she said. So Nari loved to walk, and she thought that if she could just walk a little bit further and a little bit faster and a little bit more often, she'd outwalk the cognitive cobwebs. She kept on walking, which she had done very well all of her life, but post-diagnosis, this healthy, problem-solving, task-oriented way to get places was known in some circles as, anybody want, wandering. That's right. Knowing she had a terminal diagnosis, she purchased a book on the topic and established a goal of celebrating their 50th wedding anniversary, which was only 4 years away. Didn't seem unreasonable. But when she entered residential care, she was placed in a secure unit because she was a flight risk and a wanderer. That's right. So my question is, was she seriously expected to sit for the rest of her life? Who wants to sit for the rest of their life? We have enough trouble doing it 2 days at a conference. She spent the last year of her wonderful, adventurous life in high level of care, never once trying to leave, but spending every day in the garden, and boy did she continue to flutter her eyelashes at the lovely young podiatrist during his visits. And I know this woman well because this woman was my mother, and she died 6 months prior to her 50th wedding anniversary. And she's the reason that providing dementia support now is my vocation and the rest of my life. Now, I'd just like to draw your attention to some of the feedback that we're getting now from people with young onset dementia, because we live in an age of social media. And somebody said yesterday that this age group is so different to, in fact, it might have been this morning, so different to their parents. So Kate Swaffer, 49 at diagnosis, has penned, dementia is the only terminal illness where we are not told to fight for our lives, nor are we provided with an ethical pathway of support, including rehabilitation. We need support to live, not just to die. And that's the point, support to live and not just to die. So the Dementia Network is working really hard on exactly that, with some help from the Primary Health Network. And I can't actually read that because this is too microscopic. But Christine Bryden, you know, people say, with a diagnosis of dementia, you're losing yourself or you're losing somebody that you love. Well, Christine's actually arguing back beautifully, saying, hang on, which self? Which self, and at what point am I lost? And who's deciding that? It's very, very thought-provoking, but I can't read it. I'll let you read for yourself. So, health professional apathy. If the diagnosis were cancer or MS or Parkinson's, would we do things differently? When I had a gentleman who was 63, depressed, lost his job, was feeling guilt over an uncharacteristic affair and much anxiety, his GP actually said to me, no one can help him. He has dementia. He has apathy and no insight. So, the moral of the story is, if you don't know how to support somebody with young onset dementia, please refer on to somebody else who does. So the statewide Dementia Clinical Network has put together a dementia enablement guide. So this is a prompt freely available, and it's for GPs to help have those conversations around what would be helpful for a person. So if a person checks in with their GP with their new diagnosis of young onset, whatever, dementia, then the GP's got some notion about what things that he or she might be able to help support. And am I out of time? Okay, alrighty. Now, enablement is not just about allied health. Enablement is absolutely anything. So in my mother's case, she was enabled by Big W, who continued to allow her to work. And Carrie, who at 49 actually took up study. So she didn't need so much in the way of allied health, but she continued to study. She's now got a diploma and she's putting it to very good use. So enablement is just about helping people to get on with whatever it is that's important to them. It may be through allied health channels, it may be through continuing to work, it may be through correspondence as it was for her. It's whatever works. So let's just help to enable people rather than writing them off.